A very good evening and welcome everyone. On behalf of Voice of Healthcare and Viatris, allow me to extend a warm welcome to all the panelists who have joined in for today's discussion. And the viewers who have logged in for today's live discussion, a very warm welcome to you as well. Today with our expert speakers, this panel discussion aims to focus on the liver cancer treatment in this country with the lens that is beyond medicines. And to speak on the topic, I would now like to introduce the speakers. We have Dr. Sivaram Ganesamoni. Sir is Senior Consultant, Senior Oncologist at MGM Hospital, Chennai. Welcome to you, Dr. Sivaram.
Thank you.
We have
Glad to
Dr.
be part.
Aparna Sreevatsa. Thank you, sir. She's Consultant Medical Oncologist at Nanjappa Healthcare. Welcome, Dr. Aparna.
Thank you.
Thank you. Dr. Abhishek Yadav. He's Consultant Medical Oncologist at Yashoda Superspeciality Hospitals. Welcome, Dr. Abhishek.
Thank you. Thank you, Khushbu.
Along with leading with his expert views, Dr. Abhishek would also be leading this conversation and moderating this discussion. So over to you, Dr. Abhishek, without further ado.
Thank you, Khushbu. Thank you, VOH, for this platform and to discuss a very important disease that is troubling the country. And unfortunately, the database and the facilities and the importance that has to be given to this disease has not been given yet. So today in the discussion, we will try to in a very short duration, we will try to discuss the epidemiology, the concerns, the major aspects of treatment, and what is lacking in the Indian scenario about the treatment of hepatocellular carcinoma that we are going to discuss today. So I think the first point of discussion that I would like to take is how is the rate of incidence of liver cancer different in India as compared to the other parts of world? And what can be the potential reasons of the difference of incidence? Dr. Shivram, I would like you to take up to this. I would like you to take up this question and please enlighten us about this important aspect of this disease.
Yeah. When compared to certain high incidence regions like in East Asia, the incidence in India is considered relatively lesser. Relatively. Still, India is also one of the endemic regions for hepatitis B virus, a major cause for liver cancer. And alcoholism is also quite prevalent in our country. The more important point to note is India may contribute, globally, if liver cancer is the fifth leading cause, fifth common cancer. In India, it is still the 10th most common cancer. But the number of deaths due to liver cancer, the highest number of deaths in the across the globe, they come from India. So in India, liver cancer has a much higher mortality than many of the other countries. So that is a cause of concern. So that way, even if comparatively more number of people die due to the disease, so we'll have to introspect and set it right.
Dr. Shivram, what do you think? What are the reasons that India contributes so much to the mortality of hepatocellular carcinoma in spite of the low incidence? Are we just looking at the tip of the iceberg in terms of incidence, or are we diagnosing it late? And if we are diagnosing it late, then what do you think are the reasons for diagnosing it late?
Yes, of course, we are diagnosing it late. That is the most obvious answer. But why will be a much more pressing question, which if we can identify, we can also correct. So cirrhosis, though very prevalent, we don't yet have a common national program, or the disease is not considered serious enough to initiate screening of all or for liver cancer across the country. Certain governments and regional programs have been there among high-risk populations to initiate screening programs, but they have not been on a global or a pan-India scale. So across the huge country with the demographic variations, it's going to be a huge challenge. So the onus is going to be on the individuals and local healthcare providers. They have to lead the way rather than waiting for the government to pitch in. So early diagnosis can be a challenge because in the milieu of liver failure or liver cirrhosis, hepatocellular carcinoma most often occurs in a background of cirrhosis. And cirrhotic patients, as it is, they are a huge burden on the society, for healthcare system, the strain. And on top of it, there is no single program or no single test to find out uh, hepatocellular carcinoma in an early stage. So we need to have a combined modality program, which may be quite intensive and may need repeated follow-ups. So these logistical challenges are the primary reason why it is diagnosed pretty late.
Sir, do you think the one of the main problems of diagnosing it late and the weak screening program in our country, in spite of such high incidence of hepatitis B, is that probably our gastroenterologists are not trained for this disease, the screening part and the diagnosis part, because primarily the cirrhotic patients and the patients with portal hypertension, they are being the gastroenterologists are the primary caregivers. So they come to us only when it is end of the road
Yeah, when it
almost.
is florid and it is self-evident. So we are not actively looking for. Probably there has to be a common program initiating every maybe a registry for cirrhotics. Though transplant has come in a big way, and there are certain states, especially in our state, there is a very robust cadaveric program. Also, a lot of transplants going in, and I'm sure every part of the country transplants have taken a huge step up in the treatment of liver diseases. The same sort of awareness for liver cancer is not yet quite there among patients. So we say that liver failure and cirrhosis, though, can lead to death. I mean, the we don't yet create the necessary noise about liver cancer and sensitize people to that possibility. Very often, even when in retrospect, whenever we see a patient with hepatocellular carcinoma, the earlier scans often overlook a potential nodule, or only when
Absolutely.
the patient gets beyond surgical measures, you get the diagnosis. So there
I
is a
agree
little
with you,
late
sir.
presentation, and I
I
agree.
ag- I agree with you, sir, and I feel if we sensitize the gastroenterologists to actively look for this disease and to keep the patients of cirrhosis under surveillance, then I think we will be able to diagnose it at much earlier age, at much earlier stage, and then probably we'll get the patients in treatable condition and not in the metastatic state. And then I think the overall scenario is going to improve. I think the primary caregivers being gastroenterologists, the database for the hepatocellular carcinoma in our country is very weak, and probably the healthcare structure and the healthcare infrastructure have not taken into account this very important disease, like they have taken into account lung cancer, head and neck cancer, or lung cancer or breast cancer. I think the awareness about this cancer is quite less.
Yes, not just gastroenterologists, even among surgeons, and many ways, liver cancer for some reason seems to be a neglected disease.
And neglected
Why?
disease. So in
Because
spite of
in cirrhotics, yeah,
in
in spite
spite
of
of
such huge incidents,
absolutely,
because a hepatocellular carcinoma very rarely comes within the purview of surgery. We may look
very
at transplanting them. By the time they are diagnosed, most cirrhotics are not candidates for a curative resection.
they are not candidates for
So
research. They are just a candidate
yeah,
for transplant. Yeah, I agree.
yeah, but
And
they
transplant,
may be candidates for transplant, but very rarely they are candidates for resection in the background of cirrhosis. So
absolutely,
the
absolutely.
surgical gastroenterologists or the liver surgeons, they don't feel the need to actively look for the early occur. I mean, picking up patients at an early stage. Rather, we should
Absolutely.
be probably looking at preventing cirrhosis, maybe attacking HPV, or improving overall how best we can promote. I mean, prevent cirrhosis. Once cirrhosis happens, it's going to take its own natural course. So
Absolutely.
maybe we can go one step back and look at how best to prevent cirrhosis, and what are all our efforts can be focused in that area.
Almost 85% of hepatocellular carcinomas occur in the background of uh, cirrhosis only. So, cirrhosis is something that needs to be prevented to prevent the incidence of hepatocellular carcinoma and to reduce the burden of this disease in the society. So, sir, the next question that I would like to discuss is there any relation of factors like geography, age, diet on the incidence of liver cancer? Dr. Shivram?
Yes, definitely. The clustering, if you look at it, East Asia has been always been the the high prevalence of hepatitis B, which is endemic, and the hepatite more than alcoholism, hepatitis B, and to a lesser extent hepatitis C, they correlate with the burden of liver cancer, hepatocellular carcinoma. So, of note, recently the vaccination we have started hepatitis B for all healthcare workers, and even we see a lot of general population getting vaccinated for hepatitis B. So maybe in times that is the best way to means we have a target and we have a specific vaccine which is very effective and it is not cumbersome to administer. It can very well be incorporated at a mass level. So probably I would say vaccine is the way forward, along with generally sensitizing the radiologists, the gastroenterologists, and all the care providers, general physicians, to actively sensitize patients to this possibility.
Absolutely. So, can you throw a little bit of more light on the geographical distribution of this cancer? And you think there are any age peaks, or does it
Yes,
have any
definitely.
relation?
Yes, definitely. It is a there is a bimodal peak distribution somewhere in the early between 40 to 50s, and then another peak after age 60.
60s.
So yeah, and generally males are much more affected. There is a in India especially there is a 4 times male predominance. Either we cannot. I don't know whether we can attribute it just to hepatitis, maybe alcohol, or maybe the prevalence of both these factors together in males puts males at specifically higher risk, and also significant small but significant numbers due to obesity and non-alcoholic hepatitis. So and this lifestyle changes. So despite being vaccination, so vaccination may not be the only cure or only remedy for this problem. Increasingly obesity and non-alcoholic cirrhosis. So we need to in general sensitize people to this.
Absolutely.
And
I feel that
within the country we still feel the mortality, the incidence may be similar across the cities, but then definitely the death rates or they may be very underreported, or the access to healthcare in general in tier 2 and 3 cities, uh, uh, they still leave a lot of scope for improvement. So the death rate, one of the reasons why our death rates are high is even if diagnosed almost inevitably, hepatocellular carcinoma, we never see them at a curative stage. The treatment intent has always been palliative. Very rarely we see, I mean, 1 in 100, where we try to go for a curative resection. So that has also got to change primarily.
you're right, sir. Even in my practice, I have seen that probably this case, these patients are underreported. The incidence is underreported. We see many more patients in comparison to what we have been taught traditionally about the incidence of this disease. And very, very rarely, as you say, that we get a patient who is suitable for resection. Transplant again is a burden. Getting a donor and then the cost of surgery. But even in my practice, I think all of you would have heard that even transplant candidates are very less. They are so sick.
And
They are
once in the presence of, there is a unique challenge with hepatocellular carcinoma in a cirrhotic. These patients uh, tend to decompensate quite rapidly. So they need, if at all, they need transplant candidates. Their window of opportunity is quite narrow. So often live donor, if it is available, it's fine. Otherwise, that adds to the logistics. Compared to because this is one of the key factors, the presence of a carcinoma, and it's got its own tendency to spread through the portal vein, the tumor thrombus, which again, in many ways, many people are not taking up patients with such complications for transplant. They tend to get in the registry and then drop out quite rapidly also.
Yeah, I agree with you. And moreover, in my practice, I have seen that we get mostly people in childhood C or in advanced childhood B. So we practically even medical oncologists don't have much options to offer them. So almost in 50% of cases, I see that we don't have anything to offer other than best supportive care. In spite of
Very true, very true. Overall, if you look at the span, one of the key reasons is the liver being the seat of all synthetic function. And if there is liver function, that we are faced with two challenges: to fight the disease and also to fight a basic, comorbid condition, which is liver failure, which is very often, and these patients may have come in with huge ascites and quite rapid. These symptoms can be.
They keep on decompensating amongst in the decompensated episodes. You have to stop the medicine. So practically, it's a really big challenge, not just for surgeons, even for the medical oncologists
Yes,
to
if I
deal with these.
remember, before the era of sorafenib and TKIs, there was hardly anything that was given apart from tender love and care and best palliative care.
Absolutely.
So
Now the immunotherapy has come up. I think I'll take up this question with Dr. Aparna later on. Even with the advent of immunotherapy, the cost is so high that practically very few people are able to afford. We don't get the child criteria suitable for giving immunotherapy as well. So the next point of discussion I feel is a very important one, and I think which forms the crux of today's discussion. What are the screening guidelines for liver cancer in Indian perspective? What would you like? What would you suggest, sir? How should we screen? Who should be the screening candidates? What should be the modality of screening? How frequently the patient should be screened?
yeah, see, high risk population. So definitely, we've already discussed that in a background of cirrhosis, hepatocellular carcinoma is quite rampant. So it's almost, we can say, so much more that almost always that there is a background of cirrhosis in a hepatocellular carcinoma. Given that knowledge, cirrhotics become the high risk population who lend themselves amenable for screening. Despite this defined population, the target population is very defined. The number of cirrhotics is not going to be huge given in any hospital setup. We still fail to pick hepatocellular carcinoma when it occurs, when it can still be treated suitably. So there comes the challenge that again highlights that as of now, there is no uniform or standardized guideline that we can recommend. We do, and no simple modality, single modality like an ultrasound. We may do a fibroscan, we may do a AFP. None of this is going to definitely pick up at none of them are uh, specific enough to diagnose hepatocellular carcinoma at the early stage. And in the background of cirrhosis, there is always going to be a regenerating nodule and the patient's willingness to go for a surgical treatment or an early transplant. If you look at, honestly, I've already said this, that very few patients, if ever, are going to be candidates for a resectional surgery. So as a surgeon, the surgical armamentarium is going to be looking at for transplant. So that is the realistic way forward. If you are going to screen somebody, rather you are going to be looking at from a transplant perspective. I think in my viewpoint, I have it like that. Every cirrhotic patient, when he develops hepatocellular carcinoma, is a transplant candidate till he drops out of that window when he goes into a palliative care or a medical sort of a setup for various reasons. The reasons why a transplant may not be contemplated may be due to logistics, maybe due to lack of donor at the right time, or other socioeconomic conditions. Often we see what we have seen in the last 15 years is the criteria for transplant, they have continued to evolve and continue to be more and more encompassing, right? So initially we had to look at, even now all through the world, we use the Milan criteria and the USCF criteria, which are very small, like very number of 3 nodules or 8 nodules that way. In 2016, these are all there for the last, so I would say 2 decades. So even now, for a patient to be eligible for a transplant, he needs to satisfy one of these criteria. Okay, and if they go out of this criteria, they also get dropped off the transplant waiting list. That is, while they are waiting, if they are going to, if the tumor is going to grow big, they also drop out of that transplant window. So this is where the role of bridging treatment and oral medicine come in. We'll discuss about that later. I think there are experts to do that.
Dr.
It is
Aparna,
important.
yeah, sir, please.
Yeah. So as of now, one change that we can consider is This is a policy change that we can consider, that patients in India, we are even across the world, we need to expand this criteria. Now there are recent, like the extended Toronto guidelines, which would say for a transplant, to say as long as the disease is within the liver, even if it involves the entire liver, if there is no extrahepatic disease, it is transplantable. And there are contraindications for surgical, because we have seen that the overall outlook, if not for transplant, is quite dismal. And the medical treatment in the current era is not going to be with a curative intent. So, given that, we should be pushing for more and more transplant. So, as a policy, we can look at expanding the transplant criteria. So, that could be a suggestion. And with the screening, I think once they are into that screening, I mean, into that window, once they are cirrhotics and documented, we need to have a very rigorous protocol, maybe frequent, much more frequent use of ultrasound. That much I can say, though there is no consensus on it yet.
Dr. Aparna, I would like you to take up
Yes.
the same question, because this is such an important question that I wanted to. This question was actually for you, but I wanted to take sir and you both. I wanted to take this question by taken this question by both of you, because I wanted to have the prospect of the opinion of a surgical oncologist as well as the medical oncologist. So, what with the availability of so many guidelines, the ESMO guidelines, AASLD guidelines, that is the American Association for Study of Liver Disease guidelines, the NCCN guidelines that we mostly follow. I what in which guidelines I think you believe in? What should be this
So first of
exactly the
all,
screening guidelines?
yeah. So first of all, I agree with what Sir said, that high risk population, these people who have cirrhosis, who are chronic hepatitis, this alcoholic cirrhosis, who are under follow up, they have to undergo the screening as per the guidelines. You do ultrasound every 6 months and keep looking for anything suspicious of malignancy. But the problem with screening, Sir has already mentioned, that you pick up small nodules less than 1 centimeter. You cannot biopsy it also. You don't know whether it's a regenerative nodule or a hepatocellular carcinoma itself. So that's one of the problems, and where maybe we can take the help of alpha fetoprotein and try to correlate, keep under very, maybe you repeat the ultrasound after 2 months, and maybe we can tackle that situation, or do a CT scan and see what is happening. So I think multimodality to the usual guidelines that we have ultrasound every 6 months, maybe we can add another modality like an MRI and see whether it's really a regenerative nodule or a hepatocellular carcinoma. The problem of cirrhosis, I think in my practice, what I have seen is the gastroenterologists, the medical gastroenterologists are actually doing a good deal of screening and they are taking care. But the problem is, where are the gastroenterologists? They're all in metropolitan cities. So I'm sure Chennai will have 10 gastroenterologists. But what about the tier 2 cities? What about tier 3 cities? Where are the gastroenterologists? Where is cirrhosis being diagnosed? So I think the whole approach should be to decentralize. By the time the patient comes to a surgical oncologist or a medical oncologist or gastroenterologist, it's already too late. Usually the physicians, primary healthcare physicians, they diagnose, they refer it to a higher center for further management. But I think what we need to do is, India being a rural population, 65% of India is in rural areas. So I think our primary healthcare infrastructure we have to improvise. And usually in the PHCs, we do see they do simple things like CBC, creatinine, bilirubin. They're all doing it, but what they are lacking is a radiologist. They don't have an ultrasound facility. I think that may be the first tool that we should give to the doctor who is working there. And I think more and more specialists should want to work in rural areas. May not be rural, like a tier 3 city, where you can diagnose. And not only that, the problem is with cirrhotic patients. So many other they are not frank cirrhosis patients. They are having this chronic hepatitis, this non-alcoholic steatohepatitis. So they just get diagnosed with HCC, and I think one is sensitizing the healthcare practitioners about the burden of HCC, that it's a very aggressive disease and we have to keep our eyes open, and we have to diagnose it early. And the second problem is, I think the screening for HCC is a very it's not a very easy topic, because it happens not only in cirrhotic patients but non-cirrhotic patients. Just like they'll have obesity, tobacco, diabetes, and other challenges, other risk factors,
Metabolic
and they
syndrome,
develop
metabolic
HCC.
syndrome.
Metabolic syndrome in South India, it is very common. So I think early detection should be our mantra and not screening, because cirrhotic patient, they are a sinking boat and we can't do much. We can't push for transplants also. And our aim should be early detection, so that at least we should sensitize the practitioners that if you see the symptoms of HCC, they're very vague: nausea, abdominal distension, abdominal fullness, weight loss. They're very non-specific symptoms. And many patients, they think that they're having gastritis, they pop in antacids, PPIs. So that's very rampant in our country, that we self-diagnose, self-medicate. And even when they go to doctors also, they first prescribe PPI for 15 days, 1 month. So I think we should sensitize the practitioners that the incidence of cancer is increasing. The incidence of HCC is high, being an endemic area for hepatitis B. So we should sensitize people that if they have symptoms more than 15 days, they should promptly do a simple ultrasound of abdomen and look for lesions. So I think we should consider, along with screening, we should also consider early detection as our goal, so that if we detect it early, suppose a patient, not all our patients with HCC are hepatitis B positive, not all are hepatitis C positive, not all are cirrhotics also. So if we detect it in early stages, maybe there is role for hepatic resections also. And as sir said, Milan's criteria, we should see to it that we catch patients who are eligible for resection. I think that's what I feel about it.
Dr. Aparna, as far as the data says that 85% of HCCs occur in the background of cirrhosis. Only 15% are those who don't occur in the background of cirrhosis. So what do you think? What is the population? Would you like to screen a hepatitis B positive patient for HCC under some circumstances
Yes,
or
of
some
course.
special cases?
Hepatitis B, sir, as I said, hepatitis B positive is a subset of patients who go to gastroenterologists or who are with physicians and they are getting treatment. So they are usually under constant surveillance. If they have a high viral load, if they are having some particular genotypes of hepatitis B, they are usually under constant surveillance. But so many patients, they are positive. I mean, they are diagnosed with HCC who don't have frank cirrhosis. They'll have cirrhosis. I mean,
There is a bridging cirrhosis,
we do get,
bridging cirrhosis,
yeah,
bridging
yes,
fibrosis. So the
yes,
patients who have a bridging fibrosis, I think, are the candidates to be kept under screening, and those who have a viral load of more than 10,000 copies per ml. I think they are the two populations which, in hepatitis B infected population, who are at high risk for developing hepatocellular carcinoma, and they should be under screening.
yeah. But what I meant was that if a patient is under the care of a gastroenterologist, they are safe. They are in safe hands. They are those who are undiagnosed, like chronic hepatitis, people with cryptogenic cirrhosis, and this NASH, non-alcoholic steatohepatitis, that is also a major burden in our country.
Yeah. And do you think, Dr. Aparna, what is the reason that in spite of hepatitis B being so common in India, the incidence of this disease is not as high as expected in comparison to countries like China, Mongolia, or Japan? You think there is some reason?
Actually, this not only that we are vaccinating the healthcare professionals, India has this universal immunization program for hepatitis B since 15, almost last 15 years, we have been giving hepatitis B vaccines also. And maybe there are some maybe genetic different racial differences that HCC may not be so high compared to China and other countries.
I was going through a literature and it stated a very wonderful finding that the genotypes that are prevalent in India of hepatitis B are the ones which lead to development of HCC much less in comparison to the genotypes which are prevalent in the other island countries of Asia. So I think that is one of the main reasons. Second reason is that the transmission of hepatitis B in India is horizontal, not vertical. So I think the mode of transmission in the genotypes, I think they are also a major factors that, in spite of being most of the population being non-vaccinated for hepatitis B, such a high prevalence of hepatitis B, we are still not facing the problem as much as the other island countries of Asia. So you agree with me, Dr. Aparna?
Yeah, maybe, sir. Actually, the problem in India is that where is the database? Where is the registries
These are all
that we
probabilities.
have?
These are all probabilities. As I
Yes,
told you,
I think it is underdiagnosed. Many
underdiagnosed.
times, elderly patient they don't even come to the hospital. They don't even get diagnosed. So, I think our database is incomplete. It is not a complete picture of what we
That's
are
what we
actually
see
seeing in
exactly.
practice.
The database is very weak,
Yes,
especially in hepatocellular carcinoma. Our cancer registries don't tell the entire story, and there are multiple reasons for it.
yes,
The one of the reasons they say is that it is diagnosed by HCC is diagnosed by imaging mostly, not by biopsies. So it escapes the cancer registries. So they
yes.
say one
That
of the
is the
main reasons.
problem.
And
This is one of
Again,
the
to
also,
main
do a
reasons.
biopsy, you need
sorry
an
for pitching
intervention
in.
radiologist. So, where are the intervention radiologists in
So
tier 3 cities? So, I think that's why we are not biopsying in many
absolutely.
places. What do
So
you
there
say,
we
sir?
need. So that is what I am trying to say. That is what the theme has been. Close the gap. Close the gap in the cancer care. That is the uh, we have to provide the infrastructure. We have to provide the facilities. We have to provide the services to the most deprived part of the society. So now, even in the tier three cities, we have ample amount of ultrasound centers. But since the accessibility, the cost issues, uh, probably the we need to educate people. I guess I think we have made a landmark achievement in terms of improvement in the health facilities in past few decades. And as far as from where I belong to, I have seen many ultrasound centers even in tier 3 cities. You can tell about the scenario in Tamil Nadu as you live there, but I can tell as of where I live, the ultrasound is a very common modality available. Maybe the gastroenterologists are not available in tier 3 cities. They are available only in tier 1 and tier 2 cities. But then this is the sad situation that we have to extend our facilities, we have to develop our infrastructure, and we have to look out whom to help and whom to screen and whom to provide the facilities. So the next topic that we need to discuss is which is on our agenda is while what can be done, what can be done to improve the screening program, the early diagnosis in the tier 2 and tier 3 cities. uh, some concrete steps that you can people can suggest that can be implemented and that are easy to implement, which are cost effective, and that can practically solve this problem of ours. Dr. Shivram, please.
Yeah. So as a follow-up to what Dr. Aparna was saying and what you were saying about what progress that we have made. I come from Tamil Nadu, and though I am a native of a tier 3 city, and right now I am talking to you from Nagarkoil, which is a district headquarter, which is my hometown. I'm here on an ORC. I can say that I may be biased because Tamil Nadu traditionally has been very strong in healthcare. infrastructure, there is still a lot of gap here. The gap is primarily because though there is facility, healthcare facility, and there is a gap between the end user or the beneficiary and the doctor. There are doctors and there are patients, and there is no connect in between. I mean, that is where rather than establishing infrastructure, first thing we have to utilize is the optimal utilization of the existing resources. So the simplest of that will be coming from the the community centric approaches in the terms of creating awareness. That's the simplest and most effective intervention. Empower the community in terms of information. I remember one of the very popular I often remember it because the year that I joined medical school, WHO made a prediction, that is in 1996 end to 97. They made a prediction that by year 2020, one-fourth of Indian population will be afflicted by HIV. That was a statement when I was in a first year medical school, and it was an astounding statement by WHO. Now, what followed? We are in 2022, and now we know that it does not come true. But this was an official statement by, they were quite categorical. They said at the current rate, uninhibited, by year 2020, every fourth person in India will be a HIV victim. So what has happened? We won over it in a way. Today, we do not talk about HIV as a global health problem, or definitely not in India. It came through, if HIV transmission or the problems of HIV can be sorted out by empowering the people, very many ways, HPV is also something like that. And though there is also an added powerful vaccine. So I would say the first step is to educate the people about the importance of hepatitis B, the need for vaccine, even as part of the universal program, or voluntarily also. Even non-healthcare workers can also get it. It is not very prohibitively expensive. It can be made available across the community also. We have seen many number of camps where hepatitis B vaccine is delivered. Just like our current COVID camps, I have seen hepatitis B camps being organized by various clubs and NGOs, Rotary clubs doing it, Lions Club doing it, the community participation, and blood bank. We again in Tamil Nadu, we have a lot of this blood bank infrastructure, a lot of blood donation activities going on, and alongside we can have enlist volunteers to spread the awareness about hepatitis B and its ill effects. So preventing, the one area which sadly is lacking across is probably I would say, and then not dwell further on it, is prohibition. I know alcohol is a evil which the society can better do away with, but then that is for another debate. So at least we can sensitize people that when they are hepatitis B, and these are risk factors, and they need to get screened. So the first thing I would say is community participation and increasing the awareness of this disease, that what is cirrhosis and what are all the early signs of cirrhosis that patients should be looking for, and so that they themselves come and reach the healthcare facility. The problem has always been establishing a healthcare facility is much easier, but bringing the patients to there and then to avail of that facility, that is where the gap is currently is there, and that is where the gap can be closed much faster also, rather than we reaching out. If the patients come voluntarily, there has to be a way, find a way. The other thing, I agree that the healthcare infrastructure has greatly improved. Even in tier 2 and 3 cities here, we have gastroenterologists, many number. Dr. Aparna said probably there are 10 gastroenterologists in Chennai. No, even in every tier 2 city, there will be much more. Chennai probably will have about 700 or 800 gastroenterologists, big enough to have societies. Anyway, so the other thing is empowering the healthcare workers. Next level, first level, at the community level, we have to create a lot more awareness, like how to prevent the further transmission of hepatitis B, or what to do in terms of hepatitis B. In Tamil Nadu, the treatment for hepatitis B is totally free. Hepatitis, both for
Oh, that's
hepatitis B and
great.
hepatitis C. In
That's
every
great.
healthcare facility, till there is zero conversion, it is all free. It's been like this for the last 10 years. So that I
That's
would
great.
say, we have to attack not just cirrhosis, we have to go against hepatitis B. And it is very much possible. If it is possible in Tamil Nadu, I think it is possible across the
Everywhere.
country. It is just a matter of policy decision. Next, empowering the general healthcare workers, because every time me being an oncologist, I greatly believe in this concept of opportunistic screening. We may not be able to screen everybody at, we have to extend the possibilities of screening. When a patient is there, that is when, I always say at least 10, we can pass on the message to 10 different people who are sensitized and receptive to that information at that point of time. So whenever a patient get diagnosed with breast cancer, for example, we say that get all the sisters get into a mammogram program, get their neighbors into a mammogram program. So that is one point of start. When we have a target, just expand the target. That is one way I believe is again closing the gap. And once they are listed, giving them a proper schedule. Many a times, the doctors, have to take that responsibility on them, not just schedule patients on the next visit, but then give them a comprehensive overview of what is their program is going to be, what is expected out of them, how often they should report. There has to be a clarity. So these all cost nothing, means making optimal utilization of existing resources, I would believe, is the first step to closing the gap.
Thank you, sir. Thank you so much. Uh, the next topic that I would like to take, as we are running out of time, I guess. Dr. Aparna, can you please summarize in a few minutes about the treatment options available for liver cancer? How
Yes,
should we
so
approach? How
treatment
should we
option.
approach the patient?
Yes, so it all depends on at what stage have we picked the patient. So many a times already, I think 1/3 of the patients are already having distant metastasis by the time we diagnose. So they are not the patients for curative treatments, but though we have many other treatment options for them, they're not for curative treatment. So if they are diagnosed in resectable stages where resection can be done, so we'll look into how the background liver is. Is it a cirrhotic liver? If we do a resection, can the liver manage and regenerate, or can the patient withstand the procedure? What about the medical
The hepatic
comorbidities?
reserve, the reserve, the
So
reserve,
the hepatic reserve as well as the patient's overall
general
physiological
condition.
reserve, general condition, the performance status of the patient. And if we cannot do resection, maybe because of the location of the tumor or because of the comorbidities, can we do non-surgical? There are multiple non-surgical options where we can do a radiofrequency ablation, we can do a transarterial chemoembolization, we can even do radiotherapy. The stereotactic radiotherapy is possible. So these are all theoretical possibilities, but when we are discussing the closing the gap or bridge the gap, what about the accessibility, affordability of the patient, and availability of these highly sophisticated treatment options for the patient? So usually what happens is that they get diagnosed in a tier 3 city and they have to go to a tier 1 city to get maybe a transarterial chemoembolization. So I think we have to bring the specialists to tier 2 and tier 3 cities. So these options are all multiple, but it is not available at the patient's residence. So why are the doctors, the super specialists, why are they not coming to tier 3 cities? It is not because they want the glamorous life of cities. It's actually not that way, because there is no infrastructure. When a person is
What
qualified
will they
to
do
do
after,
a
after coming
work,
there?
yes, what do? Many of them, those who go back to their native place, they get frustrated. They are not able to do the surgeries they are trained for. They're not able to do the procedures that they are trained for because there is no supportive staff. There are no other specialists. So it is not only a medical oncologist. We need surgical oncologists. We need a hepatologist. We need an intervention radiologist. So multiple super specialists have to work together. So I think we have to create that kind of an infrastructure in our tier 2, tier 3 cities, when we create that kind of an infrastructure, definitely I'm sure doctors will want to work in tier 3. In fact, many are frustrated in tier 1 cities that they want to go back and they actually want to work in tier 3 cities. I think we are taking, our country is taking small steps, and that infrastructure we are actually strengthening. And during COVID times, we had such trouble and we withstood all that stress and somehow we managed the crisis. So I think with more development and progress happening in our country, I think we should be able to create onco centers in tier 2 and tier 3 cities where super specialists would want to work. And that way, I think if every institute keeps a solid data of their own patients, the registry will fall in place. I think like these tertiary cancer centers like Adyar and Kidwai, Tata Memorial, they have their registries. We have our data, but where we miss out is in the lower down in the tier 3 cities. We have only nursing homes. We don't get the data. Patients do come, they get treated, but we don't have data. I think if we create these cancer centers in smaller towns and cities, I think we can actually provide all the treatment that we discuss. So when, and it is never too late. Even if they come in very advanced disease also, we never say that you go home and rest in peace. Even when in advanced condition also, in advanced stages also, we are very happy that we are offering targeted therapy. The hepatocellular carcinoma is a very chemo resistant kind of a disease, but we have come up with targeted therapy. We have immunotherapy. We have combination of immuno and targeted therapy. We are actually extending life even in stage 4. So I think that's a very
provided
optimistic situation that we
provided
have.
they come in the correct childhood stage to us.
Yes.
Okay. And what in terms of affordability, Dr. Aparna, you feel that
Yes.
the options like TACE, TARE, radio frequency ablation, these are very affordable, except
Not
in government
affordable.
centers, except in government
Yes.
centers, which are very few in India.
Yes. And for that kind of care, every patient has to go to Tamil Nadu for treatment, free hepatitis B treatment and all. But in Karnataka, it's not that green. But definitely, government is doing its best, like targeted therapy. Sorafenib is being provided under the government schemes. So I think our country, it's a big country with such huge burden of disease and poor, not taxpayers. Not every citizen is a taxpayer. So I think we have our own challenges, but I think our country is doing whatever best that is possible. So I think we have a long way to go, but we are taking small baby steps.
I think I would like to add one more point. The biggest deficiency that we have in tier 2 and tier 3 cities of interventional radiologists. You still get gastroenterologist, you still get surgical oncologist, you still get a medical oncologist in tier 2, tier 3 cities. It is very difficult to get a good IR, that is an interventional radiologist. And the machines for an RFA, the TARE facility. So probably I think I've seen many people who get a very good quality of life and a good survival by these local modalities. Those who are not candidates of surgery, those who cannot afford a transplant or who don't want to undergo a transplant, those not are not a candidate for transplant. So taste here and they work very well for the patients, but the problem is affordability first. Second, the availability of a doctor who can perform these procedures. Third, the cost of this treatment, which is huge in terms of Indian scenario. Looking at the kind of economic, socioeconomic background most people of our country have, so that is a big issue. I think you would like to agree with me in regarding this that we need to modernize and we need to bring up these machines and we need to modernize the infrastructure and we
And one
have
more
to
thing I would like to add, as Sir said, that connect between the doctors and patient is very important. So many times in tier 3 cities, people just don't accept that a new cancer center comes up in a tier 2 or tier 3 cities, they just don't believe that they're actually good enough. They'll think that, oh, let me go to Bangalore. I don't
That will
want
always
this
happen.
small
That will
town.
always
They
happen.
don't believe the doctors. I think, as sir said, that we have to connect with the patients and make them understand that we are actually equally qualified, and we can do the same, we can deliver the same services as the tier 1 tertiary cancer centers.
So I think, sir and Dr. Aparna, we have almost touched each and every topic that we were supposed to discuss in today's meeting. And so a one-liner take-home message from both of you. Sir, first from you.
Um, I would say change comes from within. I would place the prerogative on the individual people of our community. I like the way how Dr. Aparna put, like, we are taking baby steps, but in the right direction. So let's continue moving in the right direction towards better health for every citizen. Health is not the government's responsibility, it is an individual's responsibility. This is what I believe.
Absolutely.
Take charge of your health.
Education and awareness, I think that is most important. Dr. Aparna, you, a
Yeah.
one-liner from you.
So yes, hepatocellular cancer is a very aggressive disease, but we have gone one step ahead of the disease, and we have come up with various options for treatment. So if you get diagnosed with cancer, never lose hope. We have multiple options for treatment, even when you are diagnosed in last stage. So never say never again. And if you are diagnosed with cancer, you make up your mind and take the right treatment from the right specialist.
Thank you, Dr. Aparna. Thank you, sir, for the wonderful discussion. And I think today's discussion, we made almost all the confusions clear, and what all we need to do in perspective of this particular disease, what all we have done, and how to take steps in future that can ensure our population a safety from this particular disease. So Khushbu, I think I give it to you now. Over to you.